All right, we're talking about hematology, which is the study of blood and blood-forming tissues. This includes the bone marrow, blood, spleen, and the lymphatic system. Quick review from patho and anatomy and physiology. So bone marrow is the site of blood cell production or hematopoiesis. Hematopoiesis is primarily done in the red marrow. It's also a site of iron storage. Blood is made up of the blood cells themselves as well as plasma. Plasma makes up 55% of the blood. This is mostly water, but also contains proteins, electrolytes, gases, nutrients, as well as waste. Plasma proteins are also albumin, globulin, and clotting factors. Most plasma proteins are produced by the liver, except for antibodies, which are produced by the plasma cells themselves. The blood is further analyzed. Erythrocytes are red blood cells, leukocytes white blood cells, as well as thrombocytes these are your platelets. The primary function of the erythrocytes is oxygen transportation, leukocytes is protecting the body from infections, and platelets promote blood coagulation. So your body, as we talked about multiple times, and you're going to hear it over and over again, your body is constantly trying to achieve homeostasis. So your body has responses to injury. So if your vessel is injured, you can have a vascular response where immediate vasoconstriction occurs to kind of decrease the size of the injury until a platelet plug can form. So this is where the platelets come and aggregate at the area of injury to form a plug, and then later on the fibrin can clot on top of that platelet plug to continue the clotting process. The counter mechanism to clotting is the lysis of the clot. So this keeps blood in its fluid state to maintain anticoagulation. The logical system is the spleen. So this is in the upper left quadrant of the abdomen. It's got 4 major functions. So the hematopoietic function, it's the spleen produces RBCs during fetal development. As far as filtration, it's demonstrated by the spleen's ability to remove the old defective RBCs from circulation. It also involves the reuse of iron. It's able to catabolize that hemoglobin and return the iron component into the bone marrow for reuse. It also filters out bacteria, especially encapsulated organisms such as gram-positive cocci. The immunologic function is demonstrated by the fact that it's full of lymphocytes, monocytes, and stored immunoglobulins. And the storage, the spleen is a storage site for RBCs and platelets. More than 300 mL of blood can be stored, and that's about 1/3 of the platelets can be stored in the spleen. The lymph system, so this consists of the fluid, lymph itself, as well as the lymph capillaries, ducts, and nodes, carrying the fluid from the interstitial spaces into the blood. These are thin-walled vessels that have irregular diameter, which draw the fluid into themselves and bring it back to the filtrate everything and bring it back to the vasculature system. The liver is also a filter in this system, and it also produces the procoagulants that are essential for coagulation. It also is key for the regulator of the iron balance, and it stores iron in it when the tissue is in it. Quick picture of the lymphatic system, just so you're aware. The lymph nodes go throughout your entire body. Diagnostic studies that you're going to see in when you're in the clinic setting or you're in practice are a CBC. So this the complete blood count involves several laboratory tests. It counts your red blood cells, your white blood cells, and your platelets. Normal values are listed as you can see. You can also get blood typing and RH factor, which we're going to talk about in a short minute, as well as a serum iron level, measuring the amount of protein-bound iron in the bloodstream. Reticulocyte count, So this is the percent of immature red blood cells being produced in the bone marrow. And they can also do a peripheral blood smear. So this just looks at the size and shape of the blood cells, trying to diagnose any kind of abnormality or to assist in diagnosing diseases such as like sickle cell anemia. You can also look at an ESR, erythrocyte sedimentation rate, which is the body's demonstrates the body's inflammatory response to any kind of disease or pathogen. So RH factor as well as blood typing, you can see from this table over here which type, if you're A, who you can receive blood from and who you can donate to, separated into each type. If you are Rh negative, you can get either positive or negative blood, and Rh negative people can only get Rh negative blood. Otherwise, they may get a hemolytic transfusion reaction as their body starts attacking the blood that has been given to them. And we're going to talk more about blood in mid-semester when we do a simulation as well as a lecture when you guys are doing your mid-semester skills presentations. Some diagnostic studies that otherwise that you might see are CT. This is usually done when there is consideration of some sort of swollen lymph nodes within the body. You might also see MRIs done as well as PET scans. That's particularly in cancer patients. We may also do a bone marrow aspiration and biopsy, which there's a link right here to a video, but if you Google it, you should be able to see that. It's basically what's going on in this picture right here. They take a sample right from that iliac crest and then further analyze that to test for the bone marrow. Hematologic problems. So anemia, this is just showing a deficiency in either the number of erythrocytes, so red blood cells, the quantity of the hemoglobin, or the volume of the packed RBCs, or the hematocrit. So it is diagnosed usually with a complete blood cell count. It can also be diagnosed with a reticulocyte count or a peripheral blood smear. Causes, which I believe we're going to talk more about in a couple slides, but causes, some other diseases can cause anemia. So you need to consider the whole condition. In this case, it would be considered a condition, not a disease. For some people, it is a primary hematological problem, usually involving some characteristic changes in the red. Causes of anemia. There's multiple causes, multiple things that could be causing it. Could be issues in the stomach or GI tract and with absorption. It could be decreased iron availability from the liver, decreased erythropoietin from the kidneys, hemorrhage, bleeding, colon cancer, some acute trauma. Sickle cell disease can cause anemia, incompatible blood, so having that hemolytic reaction, as well as trauma. Some causes of anemia: decreased red blood cell production. So in iron deficiency anemia, this is pretty common in older adults. It's found in 2 to 5% of adult men and postmenopausal women in developed countries. So it may be caused by inadequate dietary intake, malabsorption of the iron itself, blood loss, or hemolysis. So this occurs commonly after GI surgery and in some malabsorption syndromes. Thalassemia. So this is a disease involving inadequate production of normal hemoglobin. It's usually a genetic disease or disorder. It can be life-threatening because it can cause growth, both physical and mental, to be slowed. Symptoms usually develop in childhood by 2 years of age and then can cause growth and developmental defects. These patients sometimes have jaundice from the hemolysis of the RBCs, and they may also develop hepatitis C because of getting frequent blood transfusions. So blood transfusions were not screened for Hep C until 1992. So these patients frequently have Hep C, which may develop into cirrhosis as well as hepatocellular carcinoma. So cobalamin or B12 deficiency, also called pernicious anemia, is usually the common cause of this. So this is when there's an absence of the intrinsic factor. So intrinsic factor is required for cobalamin absorption, and if this is missing, then this can cause this vitamin B12 deficiency anemia. So the clinical symptoms: tissue hypoxia. They may also have a sore, red, beefy, and shiny tongue, anorexia, nausea, vomiting, abdominal pain. Folic acid deficiency can also cause anemia. So the folic acid is required for DNA synthesis, leading to RBC formation as well as maturation. If this is missing, it interrupts the formation of those red blood cells. There's a few other ones that we could talk about. Anemia of chronic disease. So if your body is chronically sick, it's also called anemia of inflammation. So people with HIV, hepatitis, malaria, or have other bleeding kind of issues are prone to have anemia. Aplastic anemia. This is when the patient has peripheral blood pancytopenia or decrease in all cell types, and they also have hypocellular bone marrow. So this can be congenital or acquired, and usually about 75% of them are idiopathic and are thought to have some sort of autoimmune basis. Medications such as chemotherapy can also cause a decrease in red blood cells, white blood cells, all blood cells. Anemia can also be caused by acute blood loss such as trauma, a rupture of the blood cells, and also chronic issues such as GI disturbances. If you have extremely heavy menstrual flow or chronic hemorrhoids where you're bleeding quite often. So, chronic blood loss. So, abnormal red blood cell destruction or hemolytic issue as well can cause anemia. So, patients with sickle cell disease are usually anemic as well. And you can see that we talked about extrinsic factors such as physical trauma, which we've already talked about, antibodies, infectious. Some manifestations of anemia. So for a mild anemia, these patients may have no symptoms at all. Some of them may complain of palpitations in their chest or their heart rate, shortness of breath, mild fatigue, moderate, which you can see is a hemoglobin of 6 to 10. And this is not based on whether you're male or female because the levels are different for in regards to sexes. So these people in moderate anemia have increased cardiopulmonary symptoms like a bounding pulse, and they can feel their palpitations, dyspnea at rest, or especially during activity, and increased fatigue or malaise. If you have severe anemia, this involves multiple body systems because it's interfering with how everything is working. So these people usually have pallor. So in a darker skinned individual, you'd want to look at their gums to kind of see if they're pale or if they're nice and pink. This can also cause jaundice, pruritus, icteric sclera, the glossitis, tachycardia, angina, heart failure, heart attack, depression, impaired thought process. There's lots of things that can go wrong with your patient when they have severe anemia. One thing you're going to want to know is how do you treat this anemia? So it depends on the facility and the patient's degree of anemia. Sometimes they may get a blood or blood product transfusion. Some people may get some medications, some vitamin supplements. A lot of people get IV iron to try to replace things. They might just get a volume replacement, such as normal saline, to increase just the amount of volume in their body. They might also need to be on oxygen. And they might need to make some dietary and lifestyle changes to increase the amount of iron in their diet, vitamin C, as it helps with the absorption of iron, and make sure that they are balancing their rest and activity. So we talked a little bit about this. This is one of the most common chronic hematologic disorders that most commonly in women in reproductive years. Causes are usually an inadequate dietary intake, but can also be caused from a malabsorption, either syndrome of some GI kind of issue or surgery, blood loss from either menstruation or trauma or surgery, again, as well as pregnancy. So this is usually has a gradual development, and they develop the classic anemia symptoms of pallor. They can get glossitis with that shiny red tongue, headaches, paresthesias, burning sensation of the tongue as well. Diagnostic studies that you're going to see with these patients are HNHs, or hemoglobin hematocrit. They might also check iron. A stool guaiac test. So this is just another term you might hear for this is FOB, or fecal occult blood. We just want you to be aware that guaiac is another term that they would do just to see if you're perchance pooping any blood. They might do an endoscopy, a tube going down your throat, a colonoscopy coming up through the other side. Could also be diagnosed with a bone marrow biopsy, although that is not as common. Treatments, you're going to take some usually oral iron replacements. You should make sure that the patient takes this on an empty stomach and usually takes it with some orange juice or some fruit that's high in vitamin C. It can also be given IM or IV. You will have to teach the patient that their stool might get dark and they might develop constipation, so they should start taking stool softeners. They might also want to increase the amount of red meat in their diet, as well as green leafy vegetables. Dried fruit and eggs are also a good nutritious source to treat the iron deficiency. And again, if they pair it with some vitamin C, it helps absorb that iron better. Anemia. Like I said, if your patient is missing intrinsic factor, this is called pernicious anemia. So this is one of the main causes of vitamin B12 deficiency. Also can be caused by some kind of GI surgery, most common a bariatric type surgery, as well as chronic gastritis, Crohn's, celiac disease, alcoholism, just nutritional deficiency. Strict vegetarians develop this quite often, so they have a lot of supplements at health food stores geared towards vegans and vegetarians to replace the amount of B12. And also if they have any kind of genetic predisposal to defect of the B12 utilization in their blood. Just a pictogram showing where the area of normal absorption for vitamin B12. So if this portion of your small intestine is missing due to some kind of GI surgery, then you're going to have a harder time absorbing the B12. Clinical manifestations, the general symptoms of general tiredness or malaise, sometimes shortness of breath, especially with exertion, the sore, red, beefy, shiny tongue, weakness, paresthesia of the hands and feet is common with these patients, as well as ataxia, muscle weakness, and impaired thought processes. Again, diagnostic studies will be the same. They're going to get an H&H just to check the levels. They might do a smear then, just to see if they have any abnormal shapes. They're going to check the serum cobalamin levels. They might do an endoscopy, usually so an upper GI study, or a biopsy. They might also do a Schilling's test. So this test is a 4-stage test that involves analyzing your urine samples to determine the cause of the vitamin deficiency. So it's used to measure how well your body absorbs B12 from your digestive tract. Treatment. So these people get iron cyanocobalamin. It's usually daily for 2 weeks, and then until the hematocrit is within normal limits. Then monthly for life, these people will get some IM injections at least once a month. If your GI absorption is intact, they might be able to just use oral supplements, as well as increased red meats, eggs, salmon, tuna, yogurt, and enriched grains. Causes a decrease of all blood cell types, so RBCs, WBCs, and platelets. It also has hypocellular bone marrow, so a bone marrow biopsy might be used in this instance here. So aplastic anemia is divided into two major groups, congenital or acquired, although approximately 75% of the acquired aplastic anemias are idiopathic and thought to have an autoimmune basis. So these patients will also have the classic anemia symptoms of fatigue, weakness, tachycardia, pallor, shortness of breath. They may also have bone marrow suppression, neutropenia, or a decreased neutrophil count. Thrombocytopenia, so this could lead to petechiae, purpura, or epistaxis, a low hemoglobin, as well as low whites and low platelets. They may have a prolonged bleeding time, and their bone marrow will be hypocellular, so these people will probably have a bone marrow biopsy. So we want to see how we would prevent complications from infection and hemorrhage. We would want to know our patient's absolute neutrophil count, or ANC, to see if we need to put them in neutropenic precautions, as well as how to protect them from hemorrhage, what medications we would have on hand in case they did go into thrombocytopenia or have display symptoms of thrombocytopenia. So if this is untreated, it's 70% fatal. Some treatment options are bone marrow transplant, as well as immunosuppressive therapy. The petechiae are the small red dots. Purpura are the big ones that look like bruises. That's generally how that goes. And these can be found in the patient's mouth, any area of the body where there's any kind of skin or So we're going to talk about leukopenia. So when you hear the suffix penia, you're going to think a decrease, right? So leukopenia is a decrease in the total WBC count. Granulocytopenia is the decrease in the granulocytes. Neutropenia is a division of that, you could say. So this is a decrease in the count of neutrophils, and we talked about the absolute neutrophil count, or the ANC. So normal is greater than 1,500 cells. So if a patient has less than that, then we're going to think that they're in some sort of neutropenia. Has neutropenia, this can be caused by a variety of different conditions or diseases. It's commonly associated with chemotherapy for use in the treatment of cancer. Other drugs that can cause it, or anti-inflammatory drugs like steroids, and some antimicrobial agents such as Bactrim. Aplastic anemia, leukemia, and myelodysplastic syndrome can also cause it. Patients with lupus or rheumatoid arthritis can have neutropenia, as well as viral infections such as hepatitis, HIV, measles, and influenza. Severe sepsis also has the potential to cause neutropenia, as well as the other things listed down. So classic signs of infection are going to be impaired because they have a decreased amount of neutrophils. So these people may not have a systemic response of redness around the site of an incision, for instance. They might not also have pus that forms. They may, if they have a low-grade fever, it usually indicates a significant infection. So these patients will have usually their temperature at least taken every 4 hours. If sore throat, lesions of the oral as well as the pharyngeal mucosa, diarrhea, rectal tenderness, vaginal itching, shortness of breath, non-productive cough, These are signs of infection in a neutropenic patient. This is a fresh infection in a neutropenic patient because their body cannot fight off infections like a normal body would. They develop things like thrush that is common in infancy. So this is a fungal infection that is taken over inside of a patient's mouth. So usually when a patient's white blood cell count is less than 4,000 or their absolute neutrophil count is less than 1,000, we say they're neutropenic. It could also be diagnosed with a bone marrow biopsy as well as cultures and a chest x-ray. Neutropenic precautions. So this is something you will see, especially if you're on the 6th floor on the oncology side. You wash your hands and you wash any patient equipment you're going to bring in the room every single time you go in. So it's using those purple Cavicide wipes on, if you bring a stethoscope in, that needs to be wiped down. If you feel like you might potentially have been around someone who is ill or sick and has a cold, a flu, anything, you're going to want to wear a mask or have someone else take care of that patient. Neutropenic diet, so they cannot have any fresh cut fruit, vegetables, anything like that, as they have the potential to bring in microbes on those. We would also want to identify the site of infection in a neutropenic patient. So these people will typically have blood cultures done. If they have a Metaport or any kind of line, there would be cultures done with one of those as well as in a regular vein. These people would be on antibiotics. They might also get something called Neupogen. So this is going to stimulate, hopefully, the production of blood cells from the bone marrow. These patients will always have their own room, and they will be in community isolation. So that means if they have to leave their room, they will wear gloves and a mask to protect themselves from anything around them in the within the facility. So if they need to go on to a test or procedure, they need to put on a mask. If they're going to be touching anything other than their bed, they need to wear gloves, and they need to frequently wash their hands. Like I said before, their temperature at least is taken every 4 hours, although normally a full set of vitals is done. And we need to make sure we teach them to at least take their temperature daily when they're not in the facility, to make sure they're taking a daily shower, not being around, no gardening, no cleaning up after pets. They can easily catch things from sifting through the cat's litter box, and make sure that they wash their hands really well after petting any kind of animal. So this is just an example, a sign of a neutropenic precaution sign outside of a patient room, which is not what we use at this facility, but it would be something similar to this. And it's just reinforcing you need to wash your hands. If you think you have been sick or you've been around someone who has been sick, you definitely want to see if someone else can take care of the patient. If not, make sure you're using proper hand washing, wearing a mask when going into the room, and don't bring any fresh plants or fresh fruit or vegetables into the patient room, as those can be carriers of spores, bacteria, anything. All right, thrombocytopenia. This is characterized by a reduction in platelets below 150,000. It can be inherited, although that is extremely rare. It's most commonly acquired. Can be acquired by the ingestion of certain herbs or drugs, such as thiazide, diuretics, alcohol, chemo drugs, digoxin, NSAIDs, antibiotics, analgesics, some spices such as ginger, cumin, turmeric, or cloves, heparin, herbs like feverfew, garlic, ginkgo biloba, ginseng, things like that. Autoimmune diseases can also cause thrombocytopenia. Thrombotic thrombocytopenic purpura, or TTP, is an uncommon syndrome characterized by hemolytic anemia, thrombocytopenia, neurologic abnormalities, fever in the absence of infection, and renal abnormalities, although not all features are present in all patients. This disease is associated with enhanced aggregation of platelets, which form into microthrombi that deposit in arterioles and capillaries. Disseminated intravascular coagulation, or DIC. Although it says coagulation, it's also actually a disease of bleeding, so it is very misleading. Heparin-induced thrombocytopenia. So this can typically patients develop this 5 to 10 days after the onset of heparin therapy, and as many as 5% of patients on heparin develop HIT. These patients generally, patients with thrombocytopenia can also lead to splenomegaly as well as splenic sequestration. that are acquired are turbulent blood flow caused by hemangiomas, or a group of blood vessels, abnormal cardiac valves, and intra-aortic balloon pumps. So if your patient's on a balloon pump, you can anticipate checking those platelet levels quite frequently. I talked about these medications already a little bit. Some clinical manifestations of thrombocytopenia. These patients can present with petechiae, purpura, and ecchymosis, or bruising. They may also bleed a little bit longer after lab draws, as well as bleed from their gums, GI tract, or nose. These patients are extremely susceptible to hemorrhage, and if they get a cerebral hemorrhage, this could be fatal, GI bleeding, and prolonged bleeding time. They may also get thrombosis in some of these disorders because the bleeding does clot, and that would also lead to vascular ischemic problems. Some diagnostic studies, as we said before, the platelet count. So a CBC would show you the platelet count that would be less than 150,000. Platelet transfusions are generally not recommended until the count is below 10,000. You would also see an increased PT, an increased PTT. They might also do a bone marrow biopsy. If other tests are inconclusive, or especially in older patients of a higher suspicion of an underlying bone marrow disorder. And like I said, most of the platelets you would get from the CBC. Nursing management, things we can do for these patients. So we want to figure out the underlying cause or disorder, and then we can reverse it usually from there. But we also might need to be sure we let lab know that they need to hold pressure for 5 to 10 minutes after lab draws. We're not going to give them straight edge razors. They're going to have soft bristle brushes. We're going to make sure that they're in some fall precautions, because we definitely don't want these patients to fall. Assess their skin, make sure they're not straining during bowel movements, don't blow their nose excessively, make sure they're not on bed rest, but at least light activity. And then we could do a platelet transfusion, as I said before, for platelet counts less than 10,000. Polycythemia is a production and presence of increased numbers of RBCs. The increase in RBCs can be so great that the blood circulation is impaired as a result of the increased viscosity or thickness, as well as volume or hypervolemia of the blood. There's two different types. Polycythemia vera, it's a chronic condition. Not only are the RBCs involved, but also the white blood cells as well as platelets. This disease develops insidiously and follows a chronic vacillating course, usually starts around the 60 age mark, and is slightly male predominant. Because of the thickness of the blood as well as the increased blood volume, splenomegaly can occur in approximately 90% of the patients, and hepatomegaly is also common. These patients have hypercoagulopathies that predispose them to clotting. Secondary polycythemia, it can be either hypoxic-driven or hypoxia-independent. The hypoxia-driven secondary polycythemia stimulates the lack of oxygen stimulates the erythropoietin production in the kidney, which then in turn stimulates the RBC production. This hypoxia can be from altitude, hypoventilation, defective oxygen transport, or many other issues. And in hypoxia-independent secondary polycythemia, the erythropoietin is often produced by a malignant or benign tumor. So these generally do not resolve. I've talked about this a little bit. So it increases your viscosity as well as the total blood volume, can cause headaches, dizziness, tinnitus, and visual disturbances. It can also cause painful burning of the hands and feet. Can quickly develop into thrombosis as well as in a stroke. May also lead to hemorrhage. And then, like we said, hepatomegaly and splenomegaly. To diagnose this, we would do a CBC, and the RBCs, WBCs, and platelets would be elevated. Your uric acid may also be elevated in this. They would also have elevated histamine levels and hypercellularity in bone marrow, so bone marrow biopsy could be used as well to diagnose polycythemia. Some nursing management steps that you can assume are going to happen is we're going to at least hydrate these patients to reduce the viscosity of the blood. Phlebotomy may be done to reduce the hematocrit. So these patients have blood draws, or sometimes they may remove 300 to 500 mLs of blood every other day until the hematocrit is reduced to normal levels. Depending on where you work and your facility policy, you may be doing this, or it may be done by a phlebotomist. You may also get a low-dose aspirin or other medications to reduce, to increase the fluidity of the blood, I guess you would say. And then allopurinol can be used to reduce the gouty attacks from the viscosity of the blood. Disorder caused by a defective coagulation. So there's two types: hemophilia A. So this is a reduction in factor VIII. This is also called classic hemophilia. Hemophilia B is a reduction in factor IX, also known as Christmas disease. The labs you would see with these are PT, platelets, thrombin time, and bleeding time. Factor deficiencies like we've listed above, as well as a PTT, which would be prolonged because of due to the deficiency in the intrinsic clotting factor. Von Willebrand disease is a related disorder involving deficiency in the von Willebrand coagulation protein. So factor VIII is synthesized by the liver and circulates as a complex with the von Willebrand factor. Hemophilia A is the most common form, accounting for 85 to 90% of cases. B is about 10 to 15 cases, and von Willebrand disease is considered the most common congenital bleeding disorder, which estimates as high as 1 or 2 out of 100 people will develop von Willebrand's disease. Just giving you a quick little pictograph of mothers are generally the carriers of hemophilia. Female carriers transmit the genetic defect to 50% of their sons, and 50% of their daughters are carriers. Males with hemophilia who do not transmit the genetic defect to their sons, but all of their daughters are carriers. Female hemophilia can occur if a male with hemophilia mates with a female carrier. However, this is a rare situation. The clinical manifestations of hemophilia A and B are similar. So clinical manifestations and complications of hemophilia. Remember, A and B have similar clinical manifestations. Slow, persistent, prolonged bleeding from minor trauma and small cuts. So this patient can prick their face while shaving and then slowly bleed for days and days and days. They can also have delayed bleeding after minor injuries. This could be several hours or days after a minor injury. After dental extractions, they can have uncontrolled bleeding. Epistaxis or nosebleeds are very common. Bruising and subcutaneous hematomas are also common. GI bleeds are more common. Hematuria, or blood in the urine. Pain, anesthesia, and paralysis. And hemiarthrosis are all clinical manifestations. So life expectancy of a hemophiliac, you can see in 2010, they're up to age 72, which is not much improved from 1970 when they could live up to 68. But in the 1900s, early 1900s, they didn't live much. Many of them didn't even live into their teen years. Nursing management, we need to prevent and treat bleeding. We need to educate our patients so they know exactly what to be looking for. We need to make sure we're replacing the blood products during acute bleeds and replacing those deficient clotting factors as well. There's also DDAVP is a medication, demazapresin acetate. This stimulates the increase in the factor VIII. You can see the results of this in 30 minutes, and it lasts for about 12 hours. So this is a medication we would be giving to these patients in acute situations. Without the replacement therapy, exactly what it looks like for a trauma to a vein. All right, leukemia. This is a general term used to describe a group of malignant disorders affecting the blood and blood-forming tissues of the bone marrow, lymph system, and the spleen. So this occurs in all age groups and results in the accumulation of dysfunctional cells because of the loss of regulation of cell division. This can be progressively fatal if left untreated. An estimated 43,000 new cases are diagnosed each year. Although it's often thought as a disease of children, it affects approximately 10 times more adults than children, okay? The cause is unknown. It's generally, it has no single cause. It is now known that all cancers, including leukemia, begin as a mutation of DNA of certain cells. So chemical agents, chemotherapeutic agents, viruses, radiation, immunologic deficiencies have all been associated with the development of leukemia. Acute leukemia. There's two different kinds, acute ALL or acute lymphatic leukemia, or AML. So ALL is the most common type of leukemia in children and accounts for 20% of acute leukemia cases in adults. Immature small lymphocytes proliferate in the bone marrow. The majority of patients have a fever at the time of diagnosis. Signs and symptoms may appear abruptly with bleeding or fever, and they may be insidious with progressive weakness, fatigue, bone and joint pain, as well as bleeding tendencies. AML represents only 1/4 of all leukemias, but makes up about approximately 80% of acute leukemias in adults. It's often abrupt in its onset, and these patients may have serious infections and abnormal bleeding from the onset of the disease. It's characterized by uncontrolled proliferation of myoblasts and the precursors to the granulocytes, and there's hyperplasia of the bone marrow. And these signs and symptoms are listed right there. There's also two different types. So it involves mature cells that are classified by the predominant cell in the bone marrow. So chronic lymphocytic leukemia, or CLL, is the most common leukemia in adults. Complications are rare in early stage CLL, but may develop as the disease advances. Pressure on nerves from the enlarged lymph nodes can cause pain and sometimes paralysis as well. CML, or chronic myelogenous leukemia. The excess neoplastic granulocytes move into the peripheral blood in massive numbers and ultimately infiltrate the liver and spleen. The natural history of CML is a chronic stable phase followed by the development of a more acute aggressive phase known as the blastic phase. The chronic phase can last for several years and be well controlled with treatment, but even with treatment, the chronic phase usually progresses to that blastic phase. Early signs and symptoms are fatigue, weakness, and pallor, anorexia, or weight loss. So chemotherapy is a treatment for leukemia. So in the beginning, let's see, stages of chemotherapy. So the induction therapy is the first stage. It's the first attempt to bring about a remission. It's very aggressive usually, and it seeks to destroy the leukemic cells in the tissues, peripheral blood, and bone marrow to hopefully restore normal hematopoiesis in the bone marrow recovery. Consolidation phase, or the post-induction, post-remission therapy. This high-dose therapy is usually given after the onset, the induction therapy. And other drugs, adjuvant drugs, may be added on to try to potentiate those chemotherapeutic agents. It's usually started after remission is achieved and may consist of 1 or 2 additional courses of the same drugs given during the induction, as well as other agents. Maintenance chemotherapy, small doses of frequent combinations are usually every 3 to 4 weeks for a prolonged period. In AML, maintenance therapy is rarely effective and therefore rarely administered. So bone marrow transplant is a treatment for those patients. It really helps those with AML. Basically, it replaces the unhealthy blood-forming cells with healthy ones. In some cases, this can cure the disease. Prior to the transplant, chemo and total body irradiation are used to destroy the malignant cells, inactivate the immune system, to hopefully decrease the risk of rejection and empty those cavities to provide space for the new bone marrow. 40 to 50% of patients develop signs and symptoms of reaction or rejection. Lymphomas. So lymphomas are malignant neoplasms originating in the bone marrow and lymphatic structures, resulting in the proliferation of lymphocytes. So they are the 5th most common type of cancer in the United States. 2 major types are Hodgkin's lymphoma, also known as Hodgkin's disease, which is 11% of all lymphomas, and then also non-Hodgkin's lymphoma as well. So non-Hodgkin's lymphoma is generally more aggressive than Hodgkin's. But it is more responsive to therapy and therefore more likely to be cured than Hodgkin's lymphoma. Signs and symptoms are lymph node enlargement, hypermetabolism. So these patients will exhibit some weight loss, night sweats, fatigue and malaise, splenomegaly, hepatomegaly, which can result in jaundice. And again, if your patient have darker skin, you might want to check the sclera of the eyes or the gums to check for any yellowing. With progression of lymphomas, there can be mediastinal involvement, so a non-productive cough, dyspnea, dysphagia. If patients are unable to eat, swallow, there can be ureteral obstruction and spinal cord compression from the swelling of those lymph nodes. Some enlarged lymph nodes, as well as computer imaging. Looks like that's an X-ray. So staging of lymphoma. So stage 1 is the one we're hoping for. So this one is the most curable. As they get to stage 4, that has some involvement outside the diaphragm, so liver, bone marrow. So if they're also followed by A, it means absence, or B, presence, to indicate systemic symptoms of fever, night sweats, weight loss, things like that. Treatment in stage 1 and 2 is radiation. Stage 3 is radiation and chemo, and stage 4 is a combination of chemo and radiation, stem cell transplant as well, although sometimes in stage 4 it is palliative, so it's the hope is to just reduce the lymphomas themselves to prolong life, or at least the quality of life. NCLEX question number 1. During the nursing assessment of a patient with anemia, what specific information should the nurse ask the patient about? A, stomach surgery, B, recurring infections, C, corticosteroid therapy, or D, oral contraceptive use? And that is stomach surgery. So stomach surgery can result in bleeding, right? Internal bleeding that we can't see. Recurring infections potentially could cause an inflammatory response that might later on lead to anemia. Corticosteroid therapy is actually a treatment sometimes in anemia. And oral contraceptive use would cause more of a clotting instead of a bleeding, correct? During an assessment of a patient with thrombocytopenia, what would the nurse expect to find? A, abdominal tenderness, B, petechial and purpura, C, jaundice, sclera, and skin, or D, tender and large lymph nodes. Petechiae and purpura. So A, abdominal tenderness, because the patient has a low platelet level, could they be bleeding internally? It could be, but we would not expect to find that. Jaundice, sclera, and skin, that would not be anything in the onset of a patient with thrombocytopenia, which is a decreased platelet level, right? And tender and large lymph nodes are also not a sign or symptom of thrombocytopenia. A patient about a new prescription for oral iron supplements, what does the nurse instruct the patient to do? A, increase fluid and dietary fiber. B, take the prescription with meals. C, the iron can be discontinued once the hemoglobin levels are within normal limits. Or D, report the presence of black stools to the healthcare provider. A, increase fluid and dietary fiber. We might also want this patient to start a stool softener. We want them to take the iron supplements on an empty stomach, preferably with a glass of orange juice or something with vitamin C. And the iron we want them to continue on even when the hemoglobin levels are within normal limits for a short time afterwards, until we can figure out why their hemoglobin is so low. in the presence of black stools to the healthcare provider is going to be inevitable because the oral supplement can cause black stools. Number 4, a patient with acute myelogenous leukemia, or AML, is to start chemotherapy. When teaching the patient about the induction stage of chemotherapy, the best explanation by the nurse is A, the drugs are started slowly to minimize side effects. B, you will develop even greater bone marrow depression with risk of bleeding and infection. C, it will be necessary to have high-dose treatment every day for several months. Or D, during this time you will regain energy and become more resistant to infection. Correct answer is B. You develop even greater bone marrow depression with risk for bleeding and infection. So A, remember in the induction stage, we heavily load them with the chemotherapy. So this is entirely incorrect. It is necessary to have high-dose treatment every day for some of them, but not usually for several months. And then during this time, you will regain energy and become more resistant to infection is also incorrect because these people are generally super tired and have a higher risk of infection. So B is the only correct answer here. All right, guys, have a good rest of your day.